So I wanted to turn things over now to Chris Brandt to introduce our first speaker.
All right, thank you very much. I'd like to welcome Dan Fletcher. Dan obtained his BS in electrical engineering at Drexel University and PhD in bioengineering at UC Berkeley, UC San Francisco. I guess I didn't read this right. Before completing his DVM at UC Davis, followed by an internship and residency in emergency and critical care at the University of Pennsylvania. His current interests include immersive simulation and virtual patients for veterinary student training, and recently received a number of awards, including the 2012 SCAVMA Teaching Award for Clinical Sciences and the 2013 Cornell University College of Veterinary Medicine Department of Clinical Sciences Innovative Teaching Award. Take it away, Dan.
Great, thanks. I hope everyone can hear me. If not, give a holler. But I'm very excited to be here this morning to talk about some work we've done on immersive simulation. I know the initial listing of talks listed this as immersive simulation and virtual patients. I think Jody Korich is going to be talking about virtual patients next, and I'm excited to hear what she has to say. But I'll be focusing for the next 10 minutes or so on the work we're doing here on immersive simulation. So the problem we were trying to address when we started this project was the fact that we found, critically ill and emergent patients are very scary to our students coming into the clinic. And we find that even though our students come in with a good knowledge base about how to deal with a shocky patient, if I stop them in the hall and I describe a patient, ask them what they want to do, they can recite back to me exactly what they want to do. But then when they're in a clinical situation and they have to apply that knowledge base in real time on a real patient, it tends to be very, very challenging for them. And this is kind of what I see. The sort of deer in the headlights kind of look, actually, it looks a little more like this. But they freeze up and they're not sure what to do because even though they have that knowledge base, they've never had the opportunity to practice it, and certainly not the opportunity to practice it in real time. So I think the ideal preclinical training environment would be one where you can actually allow those learners to apply the concepts they're learning in class to real clinical cases, to collect the clinical data themselves, to then try to integrate those results of that clinical data to come up with a diagnosis and an initial treatment plan, and then to direct that case to actually administer that treatment in real time in a high stakes environment and see the results of those decisions that they've made in the patient. So to get some feedback from the patient, but also after the scenario is over, to be able to get feedback from their peers about possible alternative approaches, and also from the instructors in the room who are helping to facilitate that. And I think most importantly is offering students the opportunity to learn from mistakes. I know that personally, when I think back on my clinical career, the things that I remember the most and the things I learned from the most are the mistakes I made, and especially if that mistake had a negative impact on a patient. And so the ideal would be to give the students the opportunity to practice that kind of decision making and get that kind of feedback. So this is kind of typically what we see in our clinic. You can see that there are 4 people working on this emergency case. The 2 women in green scrubs are a resident and an intern, and you can see that they're actively engaged in evaluating the patient, administering treatment to the patient. The 2 women in the blue scrubs are students. And while they're playing a very important role, they're comforting the patient, they're helping and assisting with taking care of the patient, they're not directly involved with treating that patient, and I would argue not even really directly involved in assessing that patient. So the idea would be to let them take the role that the women in the green scrubs are taking and really run this scenario. But the problem is that obviously puts the patient at risk. If these students are not quite up to that task yet, letting them sort of practice those skills on this real patient could result in a poor outcome. And so I think we want to try to figure out ways to do this in the preclinical setting, but in a safe environment. So meeting all of those same goals, but in a safe environment for both the learners and the patients involved in the scenario. And that's where the concept of immersive simulation comes in. So the idea here is that we want to provide an environment that's safe, where the students can practice and kind of explore different opportunities and different approaches to clinical cases. We'd like them to be able to experience what it's like to run a clinical case in real time. And I think the real time aspect of this is very important, without any intervention from anyone around them. So basically the opportunity to make the decisions and see the results of those decisions. And then we want to be able to provide physiologic feedback to the students that's linked to those treatment decisions. So based on what they do, we want the simulator to respond to them differently, so that it actually makes sense, and that they'll learn what to expect in terms of response from the patients when they administer specific treatment. And then through the course of all of this, allowing that to play out in real time, but then facilitating learning from that experience through post-scenario discussion and feedback, allowing peer teaching to take place, so letting the students talk with each other about alternative approaches, things they might do differently next time, and also to provide feedback from the instructors in the room who may have more experience. So to try to accomplish that, we developed a simulator that we call Robo Jerry 2. He's kind of a mashup of a commercial canine mannequin, a rescue critters critical care, Jerry canine mannequin, and a human patient simulator made by a company called Laerdal. It's the ALS Simulator Advanced Mannequin. This is sort of their low-end human patient simulator that we took apart, and we put the pieces from the human mannequin and the dog mannequin. And so the Robo Jerry 2 has spontaneous respiration. Basically, his chest moves when he's supposed to be alive and breathing. He has heart and lung sounds that is that better? Okay, I'm going to keep going and hope that we're doing okay. If you need me to stop, just sort of holler and let me know. So Robo Jerry 2 is used in this kind of environment that you can see here. So we have a control computer that runs the scenarios, and then this is the picture on the bottom is a picture of our old simulation room, which was basically an office that we converted into a simulation center. So you can see there's a shower curtain hanging down that separates me from the students so they can't see me. Now we actually have separate rooms for this. And then in the upper left, you can see sort of the whole thing together, where we have an instructor workstation, we have the canine simulator, and the simulated patient monitor that are kind of all in sync with each other. So the way this works and the way we apply this is that we have teams of students who work on a case, and here you can see a picture of a CPR scenario, and then we have classmates of theirs who are watching remotely via video feed. The simulations run in real time, as we discussed. The students just get to do what they decide they want to do, and they can see the results of those decisions. And then at the end of each scenario, the students debrief together. So the faculty facilitator and all of the students, the ones watching and the ones participating, talk about what happened, talk about alternative approaches, what they thought they would do differently next time, and what they thought went really well. And these are very rich and I think very engaging discussions that occur after each scenario. Each scenario is programmed in advance, so this is an example of what the scenario editor looks like, and it consists of a series of states of the mannequin. So each box represents a state, and then there are connections between those states, and depending on what the students do, the scenario will flow through those different states. So you can see at the beginning of this scenario, we have a bradycardic patient who has a heart rate of 20 beats per minute. We can set lung sounds and heart sounds. We can set the patient monitored parameters as well. And then depending on what the students do, the scenario will then move through the different steps. So after 1 minute of time, it moves on to a pulseless electrical activity state. And then depending on what the students do, if they apply the CPR's algorithm correctly, they'll step through a number of states and eventually get the patient back. If they do the wrong thing, such as do an electrical defibrillation in this patient in pulseless electrical activity, they'll go into a terminal state, a terminal asystole that they can't recover from. So it's sort of like a choose your own adventure. Depending on what the students choose, the scenario will come out differently. When we first started this project, we ran a number of surveys with the students to try to get their feedback on how well they thought this worked. And the feedback was quite positive. You can see that the vast majority of students thought that the simulation was realistic, required them to think and act similarly to the way they would in a real-world case, that it actually generated emotions that were similar to a real-world case. And we really do find the students get very invested and very anxious and excited about the case as they're working through it. They find them universally very engaging, and they do feel that it helps to prepare them for similar real-world cases. And when we ask them sort of more open-ended questions, there are several themes that come up. Probably the most important one and the most consistent one is that they really like the fact that it lets them practice applying what they're learning in a realistic scenario. It also gives them an opportunity to practice communication both between team members, and we're also doing some simulations now with simulated clients so that they can practice their communication skills with clients as well. And they did point out, many of them, that they really liked the fact that they could make a mistake and learn from it and it be in a safe environment. And I think really this last comment is the one that is most important to me, that the students actually felt by doing this before they hit the clinic, they felt much more comfortable jumping in and being involved in the clinic when an emergency situation occurred. So I think that this type of training can prepare them and make them more confident so that when they go into the clinic, they can get as much as possible out of that time. So just to conclude our sort of general feelings about this work, at least in human medicine, this is a validated teaching and assessment methodology. There's a lot of work that we still need to do in veterinary medicine to sort of replicate that and prove that it is a valuable teaching tool in veterinary medicine. I'm convinced, but we're working on some studies now to try to document that. And I think it offers a really unique opportunity for both teaching and assessment of real-time critical thinking, of interprofessional and client communication skills, a way to train and assess students in clinical skills, and opportunities for peer teaching. And I think that those are really valuable discussions that happen after each of these scenarios. I think our major limitation is accessibility. It was quite expensive for us to build this. The human patient simulator we started with cost us just over $25,000 to buy, which is way too expensive. But we're currently working on our own software framework based on open source tools as well as an open source hardware platform that we're hoping to have sort of a skeleton framework done in the next 6 months, I hope. I keep saying that every time I talk about this, but we're getting very close. And our hope is to release that out into the world and to find lots of collaborators with people like you attending this meeting who want to get involved with expanding that system and making a really accessible veterinary platform for this. Just a few acknowledgments before I finish up. This initial funding came from the Cornell Faculty Innovation and Teaching Program from the Office of the Provost here. They were the ones who gave us the funding to buy the human patient simulator. A local foundation, the Triad Foundation, also was very helpful with funding. Laerdal Corporation, that makes the human patient simulator, was very helpful in sort of helping us to figure out how to take it apart and put it back together. And then one of my collaborators, Dr. Ben Kitchen, who's helped with some of our new model development as well. So with that, I'm happy to sort of tie it up and see if there are any questions or discussion points people would like to bring up.
If you have questions, please submit them via the chat tool.
Looks like there's a question about the assessment rubric. So this was, these were some of the questions we asked. It was actually a larger survey, but these were some of the questions we asked the students. In terms of following the further developments on the project, we are working on getting a website up and running. I've secured the domain vetsim.org, and we're hoping to launch a website in the next few months. That's something that I've been a little sidetracked recently with some other things I'm doing here at work, but our hope is to get that up and running soon. And that'll be a place where the code will be accessible so people can download the code we're working on and add to it. And also we'll have updates on the project. Yes, vetsim.org is where it will be. Right now you'll find just a placeholder page, but that's where it will be. There's a question about using a timer to assess the time interval for assessment and action. So the nice thing about the system, the way you can program it, is that you can set basically deadlines for when something has to happen. So that example that I showed you, well, actually that's a bad example, never mind, I'm not going to put that up. But we do have scenarios, so some of the CPR scenarios especially that we work with. If a patient goes into ventricular fibrillation, if the students don't defibrillate within 3 minutes, the system will automatically go into a terminal rhythm. So it will basically cut them off, and that's one of the, I think, real benefits of this system, is that it really does make them have to make decisions in real time, and you can build in responses for the wrong decision, but you can also build in bad outcomes for not making a decision quickly enough. And I think that's really important for these emergency and critical care scenarios.
Okay, well, thank you very much, Dan. I appreciate it. Great presentation.
All right, thanks everybody. I'm looking forward to hearing the other talks.